want to make two comments. Number one, on the quality. For the WHO Western Pacific, what we try to do is help countries develop standards, guidelines and easy protocols to follow. And then, of course, we need to identify quality indicators to make sure that, the services that being done, when we have to monitor and check and to make sure that we are up to standard. And one other comment I just wanted to add was about, access to care. We know, like as Tashi said, like for his country, it's very similar in the Pacific Islands. These are very small countries, very few professionals, and very difficult to get commodities there. But we have to also realize that even in the bigger countries, for example, in East Asia, we do have still people who are unreached, like women are being corrected less than men by about 10%. We have indigenous populations that are not being served. You have disabled people, and we have underserved populations that we still have to work on. So sometimes we're missing some people who are there, and we might be able to reach them more effectively. Thank you.
Thank you, thank you, thank you. I'm going to switch the order of questions, and let me pose a question to Divya about how do we raise public awareness to increase the eREC uptake?
I think while awareness is important, I think that is something that can only be achieved through better access. By making spectacles more easily accessible, I think then we can, that should go hand in hand with awareness, because we've seen a lot of public education efforts that focus so much on awareness, and people are probably hopeful and are looking forward to or even curious about it. But if access doesn't follow behind quickly, then I think I'm a big believer in access. So I think even without public education, if we just make refractive services and spectacles, affordable spectacles available within reach of the people, I think education will be taken care of.
Okay. So you're posing the chicken or egg question. Yeah, so they're so interconnected, yeah. So let me ask Nathan.
I actually wanted to say something about awareness.
Please.
I just think, there's so many young people who are, I'm not talking about so much about presbyopia, but more about myopia in young children. They're all glued to their phones, and they're quite influenced by big personalities and media personalities. And I think that there have been some small push advertising, like programs in Singapore where they've used influencers.
Yes.
I hate that word, but there are some influencers who are actually using their influence to do some good. Or putting glasses on cartoons, for example, just making children be aware that it's okay to wear glasses, things like that.
Yeah. Thank you, yeah. Usually when you have a target-driven program, monitoring becomes critical, and I think if you're not able to monitor, things don't really improve. In the eREC program, that seems to be a weakness in the sense we are now kind of dependent upon population-based surveys to monitor, which we know that happens once in 5 years, if at all. So I want to ask Nathan and Ming, are there other ways that one can monitor, or we have to depend only on this population-based surveys?
Yeah, it's a great question. I'm a real believer in targets of opportunity. So I like the idea for kids of school-based approaches. I think monitoring in schools is pretty easy to do. Comparatively speaking, it's one more visit effectively to come back and see if kids are wearing and see whether the new glasses power is needed. And then for adults, I think we really should focus on workplaces. Some of those are easy, factories, plantations, things like that. And I'm not saying that's the full answer, but I think given the reality, maybe, every 5 years we do one really big study. But then if we're finding that people in workplaces and at schools are generally pretty well cared for, and let's say maybe residential homes for the elderly, another relatively easy target, I think that gives us something we can work with so that we're getting regular data from low-hanging fruit, easy places. These are also the easiest places to deliver services, and so they're highly relevant. And then, every 5 years or so we splash on a big population-based study. That would be my thought.
and Tosi, I really like your idea. You know, when you present the idea, one day, one particular day, you use this opportunistic idea, opportunity screening or opportunity surveillance. In one day, among these walking patients, how many of them? I just try to understand the data. I mean, based on this, I took a lot of video on this. But then my idea is that, given the fact that WHOI has been adopted and promoted as a tool to have an easily assessed visual acuity measurement. So we actually work with the other colleagues in China. We just encourage everybody using WHO eyes as an opportunity to measure your grandfather, grandmother, I mean your family member, or just your peers, and then just measure the visual acuity. So as a way that if one day everybody doing this, then we have a quite a good data to understand IEC. Thank you.
Yeah. Good. I think we're getting a very strong argument that you measure process which happens on a daily basis, school screening or individual screening or workplace screening, or even the hospital-based service delivery. And I think if improvements happen there, eventually we're going to see that impact in the community as well. Yeah, thank you. Let me ask one of the remote participant, maybe Dr. Zheng, on innovative technologies. Now today, I think we are in a huge area where new technologies are popping up every day in multiple areas, including on refractive errors. So how can technologies help in improving either uptake or quality?
Okay, I'm Dr. Zheng from China. I'm sorry for missing the on-site meeting because of the visa application problem. I think it is very impressive for me for the iRing eye care system. They have a very good refraction error recovery system. This system, I think, in China is a very good, but it's different in different region. In the big city, the refraction coverage is no problem, but in the countryside or some poor place, the refraction coverage is still not very good. Irving said that they have 80% recovery. I think as in China, probably is not. Some in countryside or poor area, the recovery probably is less than 50%. So, but in the city, the big city, the recovery is, I think, is higher than 90% or even 95%. So it's a big diversity. So I think it's very important to have the enhanced recovery of refraction in different region. So, personally, I think if we have a very good technical system, and then we can screen or can make a very good diagnosis for refraction error first, and then we can give them free or something for the poor area. In the city, probably is for purchase, not free.
Thank you.
Yeah, I think in China, the refraction error in the elderly probably is common, but for the kid, for the school student, for the myopia control is most important. The regular or the simple glass refraction is not good. Needed more device or intervention for myopia control.
Thank you. I'd like to give a chance to Dr. Ding to supplement on any of the issues that I've been talking about. Now, Dr. Julie also talked about using technology for increasing uptake or awareness. So, Dr. Ding, yeah.
Thank you. I'm Xiaohu Ding from Zhongshan Ophthalmology Center. I think Professor Ming has said awareness is the most important barrier to the uptake of refractive error correction service. So, innovative approach is we can using short videos, given the widespread popularity of short video across all age group in China. we can produce some short videos to enhance the dissemination of scientific knowledge about refractive error correction. At the same time, we can invite some well-known ophthalmologists to participate in these short videos. By using the star effect, we can significantly increase the credibility and attract a broader audience. That's my opinion about this issue. Thank you.
Okay, thank you. So we have another 2-3 minutes, and I'd like to open it to the panelists to make some open comments. Nathan.
Just to respond to the question about new technology and its role in improving refractive coverage, we have seen that school-based models of screening have a lot of strengths. It's, we can get a lot of kids in schools, they're highly concentrated, it's cost effective. The problem is often when we do referrals of the kids that screen positive, even to relatively nearby facilities, the coverage is not always great. Not a lot of people show up.
The compliance is not.
Yeah, compliance